Sir, it is sharp 6:30. So, another thing, sir, should I hand over it to Dr. Rajiv, sir, or Dr. Raj, sir?
No, you hand over to me,
Uh,
Dr. Sohan. Huh?
okay, sir. Okay, sir. Just allow me some time.
Yeah.
Okay, sir. So, with all your permission, I'm starting the webinar.
Okay.
Good evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as the session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet serves as the digital partner of this event, organized by the Society of Onco-Anesthesia and Perioperative Care, and the focus of today's session is anesthesia for renal and urinary bladder oncosurgery. So let's begin today's session, for which I would like to invite Dr. Sohan, sir. Over to you, sir. Kindly proceed with your talk.
Yeah, good evening, everyone. And today for this urological cancer talk, we have two esteemed chairpersons with us. So, one of is Dr. Rajiv Chawla. He is the director of anesthesiology at the Rajiv Gandhi Cancer Institute in Delhi. And other esteemed chairperson is Dr. Sahajanandan. He is from CMC Vellore and currently in Muscat. So, over to you, sir. And I hope that under your guidance and we will have a good talk on how we can manage the urological cancers coming for surgery. So over to you both of sir.
Good evening, everyone. Thank you, Dr. Sohan, for our the invitation. And today we are going to have the 44th lecture series of SOPC webinars. And today we have Dr. Mamta Dubey, who is a senior consultant at Rajiv Gandhi Cancer Center and Research Center, New Delhi. And she will talk us or enlighten us about anesthesia for renal and urinary bladder cancer. Over to you, Dr. Mamta.
Hello.
You're muted.
Just 1 second. Yeah. Just a minute. Good evening, everyone. Thank you, Dr. Raj. Thank you, Dr. Sohan. And I would like to thank the organizers of SOPSI for giving me an opportunity of sharing my talk on this esteemed platform. The topic of today's presentation is anesthesia for renal and bladder oncosurgeries. So what we plan to discuss in the next 40-45 minutes is regarding the preoperative evaluation of these patients, the preoperative investigations that we need to advise before surgery, in short about the ERAS protocols in uro-oncosurgery, which are slightly different from those that we follow for other surgeries. And then we go on to discuss about the management of renal tumors and bladder tumors. Now, why we need to do this is because this subset of patients is slightly different from those that we encounter in other oncology practice. Usually, we have mostly geriatric patients, elderly patients, and obviously age-related comorbidities are associated. You can have diabetics, hypertension, coronary artery disease, or maybe all of them together. And then due to poor consumption of nutrition, they may be malnourished, they may be anemic. And also the nephrectomies and cystectomies, these are major surgeries involving major surgical resections. Therefore, the duration of surgery is long. And as a result, you can have more bleeding and the need for perioperative transfusion. Also, these surgeries are performed in positions, may be performed in surgeries in position other than supine. So we can have a lithotomy, you can have a lateral position, we can have a Trendelenburg, steep Trendelenburg, with or without pneumoperitoneum, as we may be required in laparoscopic or robotic surgeries. Now, when a patient who is diagnosed with a cancer, a malignancy, and he comes to an oncology setup, he has got a certain set of questions. They want to know the treatment options, the outcome of the treatment, the risk involved with the treatment. So, before we can answer anything to them, we will need to assess them preoperatively. So, the key aim of preoperative assessment is to identify the patients at risk of complications from surgery using validated scoring systems and risk indices. So these can be a guide in planning for surgery and the perioperative care intervention and allow informed decision making with the patient. These are certain risk scoring calculators which are available. Now, in a review of literature of the different preoperative assessment methods or intervention were studied, especially in patients who had to undergo a urological surgery. So as we can see, these are all radical cystectomy, and there are some on the next slide also where we have patients who have undergone nephrectomy, prostatectomy, or nephroureterectomy. So the parameters which were studied, the assessment methods which were studied were ASA grading, the cardiopulmonary exercise testing or CPET. Then it was the third one was fragility or the frailty assessment. Then was about preoperative anemia and iron supplementation to improve the hemoglobin. And the fifth parameter that we have is about the prehabilitation. So of these, what we have is the ASA grade and the CPET, which are of level 2B and level 1B evidence. The first one is a fairly big study comprising of more than 1,500 patients. And they came to the conclusion that a higher ASA grade of 3 or more was associated with decreased overall survival or 90-day complication rate or major complications 30 days post-operatively. So this was associated with a high morbidity. As for CPET, they realized that there are certain parameters out of the CPET which turn out, of which we have anaerobic threshold or AT as we know it, and that is a significant predictor of post-operative complications, that is Clavien-Dindo grade 3, and length of post-operative stay, also mortality. Preoperative fragility assessment was also associated with a high postoperative mortality, but the results were not found to be superior to ASA grading. Then we come to treatment of preoperative iron deficiency anemia. So it was found that obviously patients who were treated with intravenous iron had lesser incidence of blood transfusion events during surgery. And then they had higher hemoglobin at the time of admission, and even they had a shorter length of stay. For prehabilitation, the studies are too heterogeneous and we do not have enough evidence to support it, but there is nothing to go against it also. So now we come to the assessment of functional status of the patient. So we can assess it by subjective methods and by objective methods. Most common subjective assessment is by the estimation of METs or the metabolic equivalent. And the other subjective parameters are those established by American Society of Anesthesiology, the Eastern Cooperation Oncology Group, then the ECOG WHO score, and the Duke Activity Status Index score. Of these, the ECOG WHO score is the one which is being used most commonly in oncology practice for assessing the performance status of the patients. So these grade 1 and 2 patients are the ones who are absolutely normal. And 2 are those who are ambulatory, capable of self-care, but they are unable to carry out any work on their own. And 3 and 4 are the ones who are very high-risk patients. Coming to the objective assessment, I'll be talking about CPET in a slight detail so that we just know what we are discussing. So this is considered to be a gold standard and an objective measure of functional status of patients. Places where we don't have CPET, 6-minute walk test or the incremental shuffle walk test can be used as alternatives. During CPET, we make an attempt to identify patients with a reduced capacity to cope with increased oxygen demand, as may occur during a surgery, which is considered to be a stressful situation. So the patient makes a manual effort on the treadmill, and the ECG, the blood pressure, the oxygen saturation, and inspiratory and expiratory gas parameters are monitored simultaneously. And two important parameters which are measured are the peak VO2, which is the peak oxygen consumption, and the anaerobic threshold. So peak VO2 is the maximum level of oxygen consumption at maximal effort. And these are the values for males and females. Whereas the anaerobic threshold is the threshold of oxygen consumption at which aerobic respiration is supplemented by anaerobic respiration to eliminate the excess carbon dioxide. And this value of less than 12 ml per kg per minute is considered to be a predictor of in-hospital morbidity. So this is one parameter which we should be very carefully studying. Frailty assessment and preoperative anemia and all this I have already discussed. In frailty assessment, we take into account the patient's energy, cognition, health status, any functional decline, and its impact on their daily activities. So after we have assessed the patient, we need to perform some investigations to satisfy ourselves that what kind of anesthesia we'll give and how we'll go about it, how to know about the patient's general condition. So there are no guidelines available for these, but NICE along with the American College of Cardiology, Radiology and Anesthesiology, they offer general guidelines, and basically these guidelines are as per the ASA grades of the patient. So for all ASA grades, they have suggested urine routine microscopy, HbA1c in diabetic patients, and pregnancy test in women of childbearing age group. After this, they have said that if the patient is having any current medication, then we go accordingly and order necessary test. For example, hemostasis if there are patients who are already on anticoagulants or taking antiplatelets. Then if we have a finding like a heart murmur or there are some many cardiac symptoms like breathlessness, so then we can go in for further investigations like ECG or echocardiography. And chest radiography is not to be asked routinely. In ASA1 patients, apart from these investigations, a full blood count, kidney function test, and in patients over 65 years with no ECG in last 12 months, ECG is to be asked. The deadline for the investigation is that if there is no change in physical status of the patient, investigations 2 months old can be considered for surgery. Whereas for ECG, a 1-year-old ECG also is acceptable if the patient does not complain of any cardiac symptoms or any decrease in his functional capacity in the last 1 year. In ASA2 patients, ECG is to be done in all patients because they are either a controlled hypertensive or diabetic. Then coming to ASA 3 and 4, apart from these, we can also ask for lung function test or arterial blood gases if the patient is complaining of some respiratory disease. And if the patient has any chronic liver disease, then we can consider checking the hemostasis. In our institute, we are not so this thing that we ask specifically like this. We always ask for a CBC, a renal function test. Coagulation profile we are asking in all patients because, as I will be discussing later, many patients, they require anticoagulation or that is why we need to know for regarding placing the epidural catheter also. And then we ask for a liver function test, ECG, echocardiography as per the age, and viral markers. This is what we are asking usually in all our patients. Now a few slides just about ERAS protocol, and why I would like to say is this because ERAS protocols now they have been studied for many years, and the aim of ERAS protocol is to achieve an improvement in patients' preoperative status. So the protocols for urological surgery are slightly different from those that were being used, especially for colorectal surgeries. This I've already mentioned that the patient population is elderly, having comorbidities and all, and there's a high risk of transfusion. These are the steps of ERAS. Of these, the preoperative period I'll be discussing in detail in the subsequent slides. And the intraoperative period and postoperative period steps have been included in the respective management of nephrectomy and cystectomy. They have been included along with them. So the first step is counseling and education. Now, why these patients need to be counseled is because following cystectomy, urinary diversion procedures are performed, and the person has to live with a urostomy bag. So it is very important to explain the patients about the different types of urinary diversion, the need for them, and what impact these diversion measures will have on their day-to-day life. These we can do with the help of multimedia, and we can use written pamphlets or counseling. And it has been found that patients accept the urinary diversion procedures better after counseling and education. Preoperative optimization includes optimization of the medical condition and smoking cessation for 4 to 8 weeks. We all know the benefits of the smoking cessation for this duration, and alcohol abstinence for 4 weeks if the patient gives a history of smoking or alcohol consumption. Preoperative nutritional therapy is indicated in those patients who have a risk of malnutrition. So they are the ones who have reduced their oral intake significantly, say maybe 50% of oral intake they are taking for last 1 week, or they have not been able to eat food at all for more than 5 days. If the patient is complaining of a preoperative weight loss, say about 4 to 5 kg over last 1 or 2 months, there is a reduction in BMI, serum albumin has gone less than 3. So all these are predictors of 90-day survival or morbidity, and these people, they need to be given special immunomodulatory nutrition. Bowel preparation, taking cue from colorectal surgeries, ERAS protocols for urosurgeries also allow that we should not do any bowel preparation. Earlier, it was believed that the ileal loop, which was harvested for the purpose of making ileal conduit or a neobladder, could soil the field and there would be a risk of infection. But now that has been done away with. Thromboembolic prophylaxis, this is a very important part in urological surgeries, as these patients are at very high risk for developing venous thromboembolism due to a DVT. Low molecular weight heparin should be started 12 hours prior to surgery, and if not possible, then at least 6 to 8 hours after the surgery, it should definitely be started. In the perioperative period, use of graduated compression stockings is beneficial. And in those patients at high risk, we can have a extended prophylaxis for 4 weeks. Preoperative fasting of solid foods for 6 hours and clear liquid for 2 hours, that has been acceptable. This has also been validated by gastric ultrasound, which reveals a lesser gastric volume than the overnight fasted patients, and the benefit of preoperative clear oral liquids is definitely there. Patients with gastroesophageal reflux, obesity, diabetes, etc., may have a delayed gastric emptying, and we must take into care this history before allowing clear liquid or solid food in the above order. Preoperative carbohydrate loading. Oral carbohydrate containing fluids, which is complex carbohydrates like maltodextrin, 2 hours prior to surgery, has been proposed to reduce the insulin resistance. And the benefits are early mobilization, time to regular diet, and lower use of opioid analgesia. Preoperative antimicrobial prophylaxis is optional in nephrectomy patients, but for cystectomy patients, both aerobic and anaerobic commensals should be taken care of. So now we come to the renal malignancy specifically. This is the TNM staging for kidney cancers. And in this, I'm just showing the T, I'm not showing N and M. And of these, of importance to us is the T3 disease. So the T3 disease is important because here the tumor extends into the major veins, and there is a possibility of tumor embolization into the lungs, causing pulmonary embolism. And depending upon its extent, it is classified as 3A, 3B, and 3C. There is another classification which I'll be discussing just in a minute from now. The nephrectomy for renal cell carcinoma was first described in 1969. 90% of the tumors are renal cell carcinoma, and the remainder are transitional cell carcinoma or Wilms tumor in children. The incidence is twice as much in males than in females. Age of onset is usually the 7th decade, and risk factors being smoking, obesity, hypertension, asbestos exposure. Clinical presentation could be hematuria, loin pain, or a palpable mass, or sometimes patients have non-specific symptoms like malaise, weight loss, and fever, unexplained fever, for which when they get diagnosed as renal cell carcinoma. Some of them may have a microscopic hematuria in a routine urine analysis. 40% of the renal cell carcinomas are now being detected as an incidental finding on abdominal imaging. And 25% of the patients at the time of diagnosis, they have metastasis to either lung, liver, bone, or brain. But evidence of metastasis at the time of surgery or at the time of diagnosis is not a contraindication to surgery, as it has been found that following nephrectomy, the prognosis of the patient improves, the outcome improves, and also the metastasis, they reduce in size. It is important to remember that unlike other malignancies, RCC is not very chemoresponsive. So usually when a patient with renal cell carcinoma is diagnosed, you will not find a patient who has received chemotherapy. So that is one thing which is to be borne in mind. The effect of chemotherapy does not have any effect on these patients. The types of surgeries that are performed are either a partial nephrectomy, also called as nephron sparing surgery, or a radical nephrectomy. So partial nephrectomy, the indications are when the tumor is of a small size or if it is a peripherally located tumor. If it is a small tumor but it is located close to the hilum of the kidney, then they might have to go in for a radical nephrectomy where it may not be possible to salvage that kidney. In bilateral tumors, we cannot do nephrectomy on both sides, so they try to salvage as much renal tissue as possible. If you have a patient with solitary kidney or one who has a compromised renal function, then partial nephrectomy is offered to them. Radical nephrectomy is indicated in stages 1, 2, and 3, where they resect the gyrotous fascia, perinephric fat, lymphatics, and the ipsilateral adrenal gland. The techniques that are used can be either an open surgery, a laparoscopic surgery, or a robotic surgery. And the incisions could be a flank, a thoracoabdominal, or a chevron or anterior subcostal incision, depending upon the extent of the tumor. So accordingly, you can have a patient who is placed either in supine position or lateral position. When we pay, usually it is a lateral position, especially for laparoscopic or robotic nephrectomies. We should be aware of the effects of this position on the various systems. In respiratory system, the lateral position itself reduces the functional residual capacity, increases the ventilation perfusion mismatch, and causes atelectasis. This, coupled with pneumoperitoneum, which is required in laparoscopic and in robotic surgeries, can increase the FRC and atelectasis. Same thing with CVS, there is decrease in venous return and decreased cardiac output, and due to this, the BP may fall during pneumoperitoneum, and it is poorly tolerated in those patients with coronary artery disease or who already have a pre-existing low LV function. The types of anesthesia that are given for the surgeries, general anesthesia is preferred, with loco-regional for the purpose of postoperative analgesia. In patients with cavoatrial disease, that was the stage 3 of TNM classification that I talked about earlier, regional anesthesia is usually avoided, as these patients are supposed to be, they have been found to be in a coagulopathic stage, and they may require a preoperative anticoagulation. So if we give regional anesthesia, there may be a difficulty in managing the epidural catheter later on. This is the typical position of a patient who has been placed for a robotic cystectomy. We can see the patient is in a lateral position with he has been strapped, and there is side support. Also visible is the compression stockings which have been applied. It is important to note that the ipsilateral hand is by the side. So the lines all have to be secured in the contralateral hand, contralateral to the side of the surgery. And as there is difficulty in accessing the patient after docking, it is important to have extension lines so that we can administer our drugs easily. Now, Novick, he classified this cavoatrial disease, and depending on whether it is level 1, level 2, level 3, or 4, the management varies. This is the one which is most relevant to us as anesthesiologists in Onco Center. Level 1 and 2 diseases where nephrectomy is more or less like a donor nephrectomy or those performed for benign surgeries. In level 1, we can see that the thrombus is extends from the renal vein into IVC, where it is less than 2 centimeters above the renal vein. In level 2, in level 2, the thrombus is below the intrahepatic vena cava. In level 3, the thrombus is in the intrahepatic vena cava, but it is below the diaphragm. It has not crossed the diaphragm. And level 4 is where the tumor thrombus involves the right atrium. So the management of the disease of this cavoatrial tumor, it depends upon the stage of the disease and the degree of IVC involvement. And that is why it is essential to study the recent CT or MRI imaging, and then we can chalk out our plan of management. These patients may require a preoperative anticoagulation. Even some of them require preoperative angioembolization so that we can reduce the bleeding. These are patients where if we have an intraoperative transesophageal echocardiography, it is going to be a valuable tool to guide us whether the tumor thrombus has been excised completely or not. Here, like in 3 and 4, level 3 and level 4, where I said that the tumor is extending into intrahepatic IVC, at level 3, we may need to take help of a hepatobiliary surgeon who will be required to take control of IVC just below the diaphragm. And whereas in level 4, we may require a cardiothoracic surgeon services with the help of a CP bypass and a deep hypothermic circulatory arrest so that the tumor thrombus can be removed from the right atrium as well. Intra-op management of these patients, it requires a large bore IV access and invasive arterial monitoring, central venous pressure monitoring, and minimally invasive cardiac output monitoring if possible. We should have facility for warming IV fluids and warming the patient as well with forced air warming, pneumatic compression devices, as I already mentioned. Adequate type and cross-matched blood should be available because sometimes transfusion requirements can be huge and the blood loss can even go up to 1.5 to 2 liters or more. So in view of this massive blood transfusion, monitoring of coagulation parameters, additional parameters, TEG and ACT if available should be utilized, as well as serial ABG analysis may be required to manage the electrolyte imbalance or any change in hemoglobin that we can see. Transesophageal echocardiography, I'm saying again and again, in stage 3 and 4, it's a very valuable tool and it helps in visualizing most distal portion of thrombus in the IVC. It also ensures that the entire tumor is resected and detects any pulmonary thromboembolism at the earliest. So this is the transthoracic echo actually showing a tumor thrombus in the right atrium. Here we can see this is the thrombus in the right atrium. I'm sorry, I couldn't catch the TE picture of this patient, but this is how it looks intraoperatively. So this level 3 disease where we talked with the tumor thrombosis in the intrahepatic IVC, when the vena cava has to be clamped, a Pringle maneuver may have to be performed or a cross clamping of vena cava is done. And this will lead to significant decrease in venous return and output, leading to hemodynamic instability. So if the patient does not tolerate this cross clamping, we should have a facility for veno-venous bypass. But most often what happens is if there is a total caval occlusion, collaterals have developed and the blood flows through that. So cross clamping of vena cava does not result in such significant hemodynamic instability. These are the patients who will need to be managed post-operatively in an intensive care unit, as the risk of complications in the post-operative period is also quite high. Coming to analgesia, the causes of pain are multifactorial. It could be because of pelvic organ nociception, abdominal incision, and if the patient is undergoing a laparoscopic or robotic surgery, port site pain, diaphragmatic irritation, and urinary catheter discomfort. So the techniques of analgesia are also multimodal. You can use NSAIDs, but then NSAIDs, they may have nephrotoxic effects. So it is preferable to use them for a shorter period with adequate hydration. Ketorolac 20 mg has been used earlier, but the risk of gastrointestinal bleeding has not made it so popular. Then opioids, especially morphine, given IM or IV as boluses or as PCA, help to reduce the pain scores of the patient. The side effects of opioids are obviously there. Most commonly, if we are able to place a epidural catheter, then that provides a very good analgesia to the patient. And most common combination is a dilute solution of a local anesthetic, say bupivacaine 0.1%, with the fentanyl, say 2 microgram per ml in the solution, and that can be given as in the form of an infusion. What one has to know is the kind of incision that the surgeons would be taking, because accordingly we can plan our level of epidural block and make the epidural be placed as incision congruent. Then another option is a TAP block or the transverse abdominis plane block. In patients where we are unable to place a epidural catheter, a TAP block can be given where the local anesthetic is deposited between internal oblique and transverse abdominis muscle. And this is usually given ultrasound guided. We can give it single shot, or we can pass a catheter and a continuous block can be given. As this plane is poorly vascular, the drug does not get washed out easily and prolonged analgesic effects are seen. And in a study where epidural was compared with the TAP block, they found similar pain scores on day 1. Also, it reduces the opioid consumption and avoids central sensitization. So this is a slide which is showing the TAP block. Depending on the type of the site of incision, we can give a upper intercostal TAP block or a lateral classical TAP block in the triangle of Petit. So in the classical TAP block, the 3 layers, the internal oblique, transverse abdominis, and external oblique, all of them are clearly visible. And we can elicit a double pop also when we when we pass our needle. Whereas in the upper intercostal TAP block, here what we see is the transverse abdominis and the rectus abdominis, as the two muscles have fused over there more or less in the center. Then another option is a continuous infusion of local anesthetics. A catheter can be placed, one in retroperitoneal space and other in the rectus sheath, and continuous infusions can be given. Acetazolamide is one thing which has been tried earlier for reducing the visceral and referred pain. It reduces the hydrogen ion formation, which retards the peritoneal acidification. Catheter-related bladder discomfort, the incidence is as high as 47 to 90%. It can cause emergence delirium in more than 90% of the patients, and the suggested treatments are with nifopam or paracoxib 40 mg IV, dexmedetomidine given as an infusion, gabapentin 600 mg or 1200 mg. It has been found to reduce the incidence of CRBT. And pre-medication with glycopyrrolate has also been said that it helps in reducing the incidence of catheter-related bladder discomfort. Now coming to anesthesia for bladder malignancy. The bladder malignancies, there are 2 types of surgeries which are usually performed. One is a transurethral bladder resection of the tumor, and other is either a partial cystectomy or a radical cystectomy. So usually the patients, they first undergo a TURBT, and TURBT is it is used basically for diagnosis and treatment of bladder tumor. For superficial tumors, it is therapeutic, and whereas for muscle invasive tumors, it helps in diagnosis of muscle invasive tumors. So then one can go ahead with a cystectomy. Here the papillary tumors, they are fulgurated endoscopically using a resectoscope, which is passed through the urethra into the bladder. The position of the patient is lithotomy, and hips are flexed 80 to 100 degrees from the trunk, and the knees are flexed until the lower leg is parallel to the torso, and the legs are held in supports or stirrups. So we have to be careful of nerve injuries. Laterally, the peroneal nerve, medially the saphenous nerve, both these can get injured. And excessive flexion of thigh against the groin, it can injure the obturator or femoral nerve, and extreme flexion can stretch the sciatic nerve. Also to be kept in mind is the fact that as these patients are elderly, the possibility of a previous hip or knee replacement is there, and that history should be carefully elicited before we position a patient. Physiological changes due to lithotomy will cause an increase in the preload, causing a transient increase in the cardiac output. And then there'll be a slight capillary displacement of the diaphragm, causing reduction in the functional residual capacity. Also, loss of lordotic curvature of spine in the lithotomy position can aggravate an already existing back pain. The ECG is standard monitoring of ECG, blood pressure, pulse oximeter, and tidal carbon dioxide is usually sufficient. And the choice of anesthesia is a subarachnoid block, as the procedure is of a short duration. The requirement of anesthesia is usually till T10 dermatome. And if there is a complication like bladder perforation, it can be easily recognized if the patient is awake. But sometimes we come across patients where the bladder tumor is placed along the lateral wall of the bladder. And in such patients, if we have anesthetized them with only a subarachnoid block during resection with the monopolar cautery, obturator jerk or a sudden jerk of the ipsilateral thigh is elicited. So to take care of that, we need to give either a general anesthesia with muscle relaxant in such patients, or supplement the subarachnoid block with a obturator nerve block. The obturator nerve block can be given by different approaches. The first is a pubic or a classic approach, but here where it is given just at the pubic tubercle, at the obturator foramen, but the landmarks are difficult to identify in obese patients. Then the second approach is the inguinal approach, where the needle is inserted at midpoint of line between femoral arterial pulse and inner border of adductor longus tendon. But usually what is given these days is with the help of ultrasound guided. So in an ultrasound guided obturator nerve block, the femoral vessels are identified, and the transducer probe is then slided medially along the femoral crease, and then we identify the adductor longus, magnus, and brevis. So we can also identify the obturator nerve, which is bifurcating into the anterior and the posterior branch. So the anterior branch lies between the longus and the brevis, while the posterior branch lies between the brevis and the magnus. And 5 ml of local anesthetic is deposited at both these points. The use of a nerve stimulator needle is helpful, and it increases the success of the block. Coming to radical cystectomy. It is used for treatment of muscle invasive bladder cancers. It involves the excision of urinary bladder, pelvic lymph nodes, and then it involves the formation of an ileal conduit or ileal neobladder for urinary diversion. This surgery is of a long duration, and blood loss may occur during bladder dissection from the dorsal venous complex. During the course of surgery, both the ureters are clamped till we can form a ileal conduit or a neobladder, to which these ureters are reanastomosed. So once the conduit is formed, the patient is susceptible to acid-base disorders, as hydrogen ion, chloride ion, and ammonium in the urine, they get absorbed by the ileal mucosa, causing hyperchloromic metabolic acidosis. And this acidosis will need correction by alkalizing agents. The position of the patients is lithotomy, and with Trendelenburg and sometimes steep Trendelenburg if the patient is undergoing a robotic cystectomy. Careful padding of pressure points and strapping of the patient to prevent the patient from sliding down is essential, and the fact that these patients are elderly with cardiac or pulmonary comorbidities, this should be kept in mind. The robotic cystectomy is, they have been increasing over the last few decades ever since the robots have become available. The most commonly used robotic system is the Da Vinci robot system. And now we also have an indigenously developed robot system, which is called the Mantra SSI. So this can also be used for performing robotic surgeries. In robotic cystectomies, there are 2-3 factors which you have to keep in mind. Factors which are related to anesthesia, surgical factors, and patient factors. So the anesthetic factors are, just broadly speaking, as I've mentioned earlier also, there is limited access to the patient. And then we have to ensure complete immobility, because if the patient moves even a little bit, the robotic system may damage some other tissue. Careful positioning of the patient to avoid any injuries to the patient. We should be aware of the physiological response of the pneumoperitoneum on various systems of the patient and take care of the pain management. The surgical factors are that robotic arms should be docked properly to avoid any injury to the patient. There have been incidences where the robotic arms may have caused pressure on the arm or maybe the shoulder of the patient. So this has to be taken care of. And in case of major hemorrhage, a rapid communication and undocking of robotic arms is required. So this is a positioning for a robotic cystectomy where we can see that the patient is placed in a 45-degree Trendelenburg position. The hands are by the side, and patient is supported by a shoulder, and IV lines, they have extension lines so that we can administer our drugs to the patient. The effects of steep Trendelenburg for prolonged duration, it can raise the intracranial pressure, intraorbital pressure, and cause facial and orbital edema. The other effects of pneumoperitoneum are on the respiratory system, where the functional residual capacity is reduced, and it can lead to basal atelectasis and reduction in lung compliance. Also, there may be surgical emphysema in some patients. All these can lead to hypoxia in susceptible patients. So what we have to do is pressure control ventilation is preferred over a volume control ventilation. A PEEP of about 4 to 6 centimeters and intermittent recruitment measures can help in taking care of atelectasis and reduced compliance. The pressure control ventilation should be so set that we achieve a target volume, tidal volume of 6 to 8 ml per kg, but the peak airway pressures do not exceed 30 centimeters of water. These can be done by limiting the intra-abdominal insufflation pressure at 10 to 12 centimeters of water. In the cardiovascular system, the steep Trendelenburg and pneumoperitoneum, they together lead to decrease in cardiac output, reduction in stroke volume, increased systemic vascular resistance, and increased myocardial oxygen demand. So patients with reduced cardiac reserve, they may not tolerate these changes, and we should be cautious when administering anesthesia to such patients. Bradycardia and cardiac arrest, these are possible during insufflation for pneumoperitoneum. So anticipation and treatment with atropine at the earliest, and release of pneumoperitoneum to decrease the stretch on the peritoneum is essential. This is a slide showing the effect of pneumoperitoneum on the different other organs. Management of anesthesia. A general anesthesia with epidural is preferred. The advantages of epidural being it decreases the risk of respiratory depression. There is return of bowel movement rapidly. We can ambulate the patient early. The risk of DVT is reduced, and obviously the opioid consumption is reduced. So there are certain salient features that we have, at which point we have to be very careful. Following intubation, the position of endotracheal tube should be checked properly, as migration of the endotracheal tube has been reported due to pneumoperitoneum. The eyes of the patient should be taped carefully, as regurgitation of acid contents of stomach may cause chemical injury to the cornea. And padding of pressure points and strapping of patient to prevent the patient from sliding down cannot be emphasized more in these patients. Same thing, this may be a little repetitive, but this is really essential that extension lines to IV access is important. Due to long duration of surgery and anticipated blood loss, arterial line should be placed, and the central line is also helpful. Standard monitoring other than these include ECG and non-invasive blood pressure, pulse oximetry, end-tidal carbon dioxide, temperature, and peripheral nerve stimulator monitoring, because we have to maintain adequate muscle relaxation. So we may not keep a zero PTC, but at least PTC count of 7 to 8 or 7 to 10 is still acceptable. The use of a cardiac output monitoring, it depends upon the patient's cardiac status. It should be defined by that. And nitrous oxide is to be avoided during surgery. So anesthesia is maintained with air and oxygen with inhalation agent like sevoflurane or desflurane. And sometimes if we are planning for only a TIVA, then we can use the propofol infusion, or we can use sevoflurane, propofol, everything in conjunction. The target should be to maintain the BIS between 40 to 60 to avoid any awareness to the patient. Intravenous IV fluid should be restricted till cystectomy and pelvic lymph nodal dissection is completed. As the engorged pelvic veins, they increase the risk of bleeding and venous air embolism. Duration of surgery ranges from 5 to 6 hours, and the anticipated blood loss could be around 500 to 700 ml, which may need to be replaced in patients who are already anemic preoperatively. Post-operatively, if the patient has any residual muscle relaxation, it should be reversed, and extubation should be performed only after ensuring intact airway reflexes and ruling out any airway edema. The analgesia that we give is multimodal. Can use IV paracetamol 1 gram 3 times a day, coupled with epidural infusion and opioids given as boluses or PCA. The target of giving adequate analgesia is to mobilize the patient early so that his functions return as fast as possible. And DVT prophylaxis should be supplemented, as I have mentioned already. These are the references from which I have taken some idea, and thank you for a patient hearing.
Thank you, Dr. Mamta, for a excellent lecture. Now the session is open for discussion. As of now, we have only one question. Dr. Mamta, what is your opinion of role of erector spinae block for postoperative analgesia in lap nephrectomy?
Erector spinae block, it may be given, but it is not being used all that routinely. People have suggested even paravertebral block, but erector spinae block has not been so much in use. I think it is better to use a tab block in nephrectomies. In fact, even the surgeons at the time of closure, they can place a catheter in the wound.
Erectors.
And so that is also
yeah. Okay. Okay, there is one more question. Is an epidural justified for robotic cystectomy?
Robotic
Dr.
surgeries
Rajiv,
yeah, I would like to answer that. Robotic surgeries are minimally invasive surgeries. Definitely, the skin incisions are not as much, but the epidural, as I mentioned earlier, also in my slide, that epidural is helpful for ensuring early bowel movement. It is help reducing the opioid consumption of the patient. It is not that robotic cystectomy patients, they do not develop pain.
So what is your recommendation, or what is the evidence?
We are using epidurals for robotic cystectomies. In fact, our surgical side, they insist that please place an epidural. We find our patients doing much better. So in our place, we are using robotic epidurals.
I think even in the ERAS guidelines for urology, epidural is still
epidural
advised
has
for
been
radical
suggested.
cystectomy. And yeah, okay. Okay, there's one more question.
Following nephrectomy, what's the minimum urine output that is required? Following nephrectomy, I think a minimum urine output, at least we should have ensure a minimum urine output of 0.5 ml per kg per hour. That is the least we can. And if a patient has a normal urinary function, I mean normal KFT earlier, urea creat is normal preoperatively, there is no difficulty in maintaining that urine output. Do you use local anesthetic or opioid in epidural? We are using both. Intraoperatively, we usually like to give a single dose of morphine epidurally. 3 milligram is 2.2 to 3 milligram, depending upon the patient's condition and weight. And then we run an infusion of bupivacaine 0.1%. And I think in our, we have separate setups which take care of ICU and operation theater. So in ICU, what they use is they use either those Baxter pumps or PCEA pumps. And sometimes they run infusion of 0.0625 or sometimes 0.1% of bupivacaine with fentanyl. That is the procedure that we follow. We are using both of them.
Okay. So, what fluid do you use? Or in major cases, do you use any kind of minimally invasive cardiac output?
Not in all cases. Minimally invasive cardiac output, we would prefer only in patients who have got some cardiac ailments. They've
Cardiovascular
got
morbidity.
CAD, or they have low ejection fraction. People, elderly patients who show aortic stenosis or age-related those changes on echocardiography. But in nephrectomy, with those level 3 and those kind of things, we would like to use minimally invasive cardiac output monitoring also in those
Okay,
high-risk
but
nephrectomies.
in level 3, level 4, if you're using a transesophageal echo, do you still use a cardiac output monitor?
Actually, yeah, with the transesophageal echo, I mean, one cannot keep. There is one person who is always busy with that. Then with the
Yeah,
team,
I completely
so
agree. Yeah, if
intermittently
you are
only you
planning
can
to,
check it.
yeah, if you are planning to do such a case, you need another anesthetist to do your TE because
You
you
need
cannot do
actually a
both.
big team over there.
Yeah.
One person to take care
So
of the
there
case,
is,
one person for TE, other person to take care of the blood loss and blood transfusion, which is required. I mean, it is a big entire team effort that OT needs. At least you need a big OT where you can accommodate at least 15 people over there.
you have one more question. Is urine alkalinization mandatory for every case of radical cystectomy and ileal conduit? And do you have a protocol?
Not intraoperatively, but post-operatively, definitely patients require that alkalization. Intraoperatively, we have found that when the patients, some of the patients where the ureters have been clamped for prolonged periods for whatever reason, till the conduit or the neobladder has been formed, these patients, they do develop some kind of acidosis and hyperkalemia, which needs to be corrected. Although in these patients, as such, the urine has not started getting absorbed in the conduit.
How frequently do you encounter postoperative pulmonary complications
Postoperative
after
pulmonary
open nephrectomy?
complications in the form of, say, atelectasis, increased requirement of postoperative oxygen supplementation. Robotic surgeries, I don't think it is that often.
Yeah, they have asked for open nephrectomy.
Open nephrectomy, I would say the stage 1 and 2, where the nephrectomy is not all that difficult. Again, they do not have such significant pulmonary complications, but the stage 3 ones, they may have. In fact, it may be because of 2, 3 reasons. One is because of the prolonged surgery. Again, it could be because of a massive transfusion which they require. So we do encounter ALI in some of these patients. I will not be able to give you an exact percentage of the complication, but these are the patients. Sometimes they require post-operative ventilation also, and we may not be able to extubate them on table. So this is the subgroup which is a little vulnerable.
Obese
Okay,
patients
I would like, sorry, sir.
Obese
Yeah.
patients, right? Sir is absolutely right. We do have a lot of obese patients also. So these obese patients are also ones who give us some
Okay.
problem.
I would like to ask one question here,
Mm.
because Dr. Sohan and you guys are there. I would like to know the how do you practically manage patients with level 3 uh, cavo caval
Atrial disease.
tumors. Yeah. So yes, once it extends into the RA, then you may have to do it with at least a cardiac surgical backup. But in a
Definitely
practical life, we get a lot of cases where it is just extending into the RA, but surgeon feels that he can milk
can
the
be
tumor
removed.
down.
Yeah,
And
this they do.
with the help of, yeah,
Yeah,
because
we have
not
also
all
come across such
centers have
incidences.
cardiac surgical backup. Yeah, so if you can just elaborate a bit on that aspect, because not
This
all
becomes a level 4 disease where it is going just
centers
into the
which do
RA.
oncosurgery. Yeah.
Yeah, if it is going just into the, if
Mm.
it is entering also the RA, just into RA, it becomes a level 4 disease. Yeah, but here we still need a cardiothoracic surgeon. And in fact, there is one such case which we have done without taking the patient on bypass. What they do is actually then in this surgery, we did have a neurosurgeon, a hepatobiliary surgeon, as well as a cardiothoracic surgeon. First, they tried to take control at the IVC level below the diaphragm. Then they realized the tumor had extended beyond it. Although the imaging that we had was within a week, but still the tumor had extended up beyond the diaphragm. So the CTVA surgeon was standby. Then what they did was they opened up, the incision was extended slightly. Um, into the thorax, and they took control of IVC just at the point it entered the RA, just before that. They put
So they opened the
they
diaphragm
put
and
umbilical tapes, huh? The thorax was
they
opened.
opened the diaphragm and
They opened the diaphragm, and then the xiphoid process also, it was that was also opened, and then they took control of the IVC just before the RA with the help of umbilical tapes. So what the purpose is that you have to prevent the tumor from getting dislodged proximally as well as distally. So the umbilical tapes are placed at that RA IVC junction, then it is placed distally so that it does not go down. And then it is suppose you're getting a left-sided surgery done, so then we have to prevent the right renal vein also from getting blocked by the tumor thrombus if it gets embolized. So they put loops on the right side, and all these are hitched up, and then the nephrectomy is done and the tumor thrombus is pulled out. Along with it, the IVC is opened for a slit is made in the
small
IVC,
incision.
and then this tumor thrombus is delivered out along with the main tumor. Then this IVC is sutured, and before suturing it, obviously we flood the field with blood, and we flush it with saline so that all the air and everything is removed, so that we do not have any incidence of air embolism as well.
Yeah. So that was a very good explanation, Dr. Mamta. But I think as anesthesiologists doing these kind of complex cases, we should master transesophageal echo, because
Right,
these are cases where we can actually look at the thrombus in real time, because these tumors can they can sometimes it can be friable, it can break and embolize and can
definitely.
produce a pulmonary embolism.
Yeah,
And when the surgeons manipulate, they want to know whether they have they're snaring or crinkling above the tumor. So we are able to give that information.
yeah,
And
exactly.
when you clamp the IVC, this can produce hemodynamic instability. So that time, rather than shooting arrows in the blind, if we know, okay, if there's a volume problem, we can give volume. Or if the heart needs support, you can give support. So contractility, volume status. So it's very important to do these kind of cases under TE guideline guidance. So even if you have to get one extra person, it's worth it. And maybe other centers like Tata and Dr. Anjali or any of the other participant who want to comment on their experience with these kind of cases, they can probably contribute. Sir, if you have something, please contribute, sir.
How often you are doing CPET and rehabilitation in your setup?
Sorry, sir.
CPET and rehabilitation.
Rehabilitation we are
Shall we
doing.
just finish this question? I think Dr. Anjali wants to say something.
Yeah,
And then
actually, that's right. It is actually a standard of care. I completely agree with you, Raj, that using TE does count in these cases as standard of care. So in those rare instances where you do have such patients, I think it is wise to utilize that facility if it is available to you. Some of the centers may actually not possess the machine. And I also take the point that you do need another person to, you do need a large staff if you're handling this sort of a case. So I take that point. There was, I think Dr. Rajiv Chawla wanted to answer the question on.
Dr. Anjali, so only one comment from my
Yeah.
side. Like in this type of cases, like in 2 or 3 cases, I did the T in the like cases, and we actually monitored the thrombus while the surgeons were manipulating doing that. So
Yeah.
the T really does help in this type of question. If the facility is there, we should do that.
Yeah. I think Dr. Rajiv Chawla wanted to answer one question about the urine alkalization. Is it mandatory for every case of radical cystectomy and ILL content? So would you like to add anything to what Mamta said?
We are not doing it. We don't do it in our setup.
I see. Right.
I would rather like to know how many of us are doing CPAT and prehabilitation in our setups, if others could contribute.
Right. I think maybe Sohan can enlighten us. Because we do not have a CPAT.
Sorry, I didn't hear. Yes, sorry.
We didn't get that, so. Hello?
in our center, in CMC, we have a CPAT machine, but we have used it only in high-risk patients. But yeah, even though there is enough and more evidence to support it, we are not using it routinely. Even in the center where I am working now, the Sultan Qaboos Cancer Center, we don't use it on a routine basis.
So, what are the limitations to using it? Is it the duration, or is it the accuracy, or is it the ability of the patient to cooperate with the demands?
No, the thing is, at least in CMC, when the pulmonary function lab was very busy, this is much more labor intensive, because you need to do a bicycle ergono this thing, or a treadmill. You need to monitor the arterial blood gas, so it's much more labor intensive. So we cannot be routinely asking for, like, if you have 5 urology theater, or when you have so many theater and you are dealing with so many high-risk patients, it was very difficult for us to ask as a routine prognostication tool.
So if it's only crucial, then you would go in for it.
Yeah, so we rather used it for certain high-risk cases where at least the surrogate markers like 6-minute walk test is poor. Then only we used it. Or we used to use it for our lung resection cases, where we thought the predicted P of FEV1 was less than 30%, and we still want to take it. Then that is the cases where we actually used CPET.
So it widened your criteria for resectability. So you could include more patients who are operable.
Yes, because sometimes when you look at the predicted P of FEV1, it is not very accurate, especially when you are trying to do the segment counting. Otherwise, you have to do the VQ scan and count.
Yeah.
Yeah. So this role of CPAT, like so especially in thoracic surgery, it is there, and especially in this lung surgery, as mentioned by Dr. Raj, is there. But again, the problem is that if the patient cannot do a 6-minute walk test, or if the patient cannot walk, then he obviously will not able to do the CPAT, because of will not able to do treadmill or do cycling. The problem is that if the patient cannot walk on a plain surface, then especially a limitation to do a CPAT also. So in that case, I think that any other stress test will be better than CPET. But but yeah, I mentioned like, and not in all nephrectomy. I don't think will be like we advise the CPET case in all nephrectomy cases. But yeah, all the high risk cases in which patient can do some cycling or treadmill, and like patient having some lung issues or something like, or any other major abdominal surgeries involving the like compartment excision, something like that, or major thoracic surgery. In that case, we can definitely advise CPET if we have the facility.
Dr. Mamta, would you like to stop sharing your screen because?
Yeah, sure.
And then we have a final question in the chat box. Right?
I think chat box we have many questions, right? Okay. Extubation, okay.
Prophylactic low molecular weight heparin pre-op is used in all level 1 and level 2 thrombectomy cases. These thrombectomy cases, I mean, once we know there's an IVC thrombus, it is better to have some kind of prophylaxis, because we have seen that although they may be having a normal coagulation profile, you do a PT, INR, APTT, that would all be normal. But if possible, if you can get a TEG done in these patients, you would definitely see a widened R. So all level 1 is not a significant one. Level 1 we can consider maybe as normal nephrectomy cases also. But level 2 we have to be cautious. And it is always better that if we can get a prophylactic low molecular weight heparin in these patients. Do you extubate all patients on table after open nephrectomy? Most patients we extubate after table, on table after open nephrectomy, except those in which we have encountered some hemodynamic instability due to massive blood loss. Where do you prefer to send the patient for overnight monitoring, ward or surgical ICU? We routinely send all our patients to surgical ICU, depending on their condition. Even TURBT patients we send to a surgical ICU maybe for a few hours, but we do have a surgical ICU facility which is attached to our operation theater. So all our patients get shifted to a surgical ICU, and depending on what surgery they've undergone, what anesthesia they've received, then they are subsequently shifted to the ward once they are settled.
So I'll just contribute one more point here. So sorry, yeah. Yeah, so basically, there was a beautiful article in the last year's Clinics of North America. So there they have said how CPET can be utilized to decide whether the patient can go to the ward or ICU. So generally, if the VO2 max is less than 15 and anaerobic threshold is more than 11, these are the patients who should go to the ward ICU, and other patients can be potentially sent to the ward. So, but I think there will be limited centers in India where you have CPET available, and I don't know whether even that center will have one machine which may not be able to handle the kind of load which we have. So that's why I was thinking that we cannot probably offer it as a routine, but maybe used as an adjunct in risk stratification or risk modification in high risk patients.
Yes, that sounds comprehensive. Any other questions at all?
I think we have finished all the questions.
So thank you, Dr. Mamta, and thank you, Dr. Raj, and thank you, Rajiv sir, and thank you, Dr. Anjali. And it was really a good session. And thank you all the audience and all the audience who actually asked the questions, and that based on the questions we had a really good discussion. So thank you everyone, and I hand over to ClearNet.
Thank
you,
you
Dr.
so much,
Thank you,
everyone.
Dr. Sohan, and
Thanks,
thank you,
Anjali.
Anjali.
Thank you. And good night, everybody.
Thank you so much,
Good
everyone, for
night.
extending us the opportunity to host the session. So, with all your permission, I would like to conclude here and looking forward to host you again. Thank you and good night.
Thank you. Good night.